Hello, my name is Dr. James R. Golding, and you're watching A Natural Healthcare Alternative, the program dedicated to your health, longevity, and well-being. Today is the second part of a two-part series of my interview of Elizabeth Bewley and the book that she wrote called Killer Cure: Why America's Healthcare System is the Second Leading Cause of Death in America and How to Not Make It Yours. Elizabeth, welcome back to the show. And it's going to be good to pick up on where we left off. We were speaking before, we were leaving off last. We were talking about acute and chronic injuries, and it's important now for us to get into some of the core of your book in how people can advocate for their own health care within our health system. You want to pick up on that?
Sure. One good place to start is with getting an accurate diagnosis. Misdiagnosis is implicated in about 1 death in 8. In other words, in about 1 death in 8, people die because they're misdiagnosed and they would have been expected to live if they had been treated for the condition they actually had. In the emergency room or other kind of high pressure environments, misdiagnosis can run as high as 40%. So even if you're being given the perfect treatment, if it's for a condition you don't have, it's not very likely to help you. So some things that people can do to increase the odds that they'll be accurately diagnosed are, first thing that they can do is to keep a written record of troublesome symptoms. In the U.S. healthcare system, there are 68,064 recognized diagnoses. So if you just go to the doctor and you say, I don't feel well, it's not that easy for the doctor to come up with the right diagnosis. Mm-hmm. But if you keep a record and you write down the date, the day of the week, the time, what the symptom is, what you were doing when it occurred.
And the frequency, right?
Yes, yes, write down. If anything helped, if anything seemed to make it worse, how long the symptom lasted. And if you write that information down, and when you go to the doctor, you take 2 copies, give one to the doctor, keep one for yourself, you give the doctor a much better chance of being able to accurately diagnose you. Something else that you can do, if you think that you have not been accurately diagnosed, is to ask 3 questions proposed by Dr. Jerome Groopman in his book, How Doctors Think. One of these is, do any of my symptoms not fit this diagnosis? A second is it possible that I have more than one problem? And a third is, let's see what the third one is. What else could it be? So these symptoms, maybe they relate to this diagnosis, but is there another diagnosis that these symptoms could also reflect?
It might challenge the doctor to go into deep thought too.
Yes.
I mean,
yes.
or reflect more on that possibility.
Yes.
Not, and that those are good questions because it's not really confrontational.
No, it's not confrontational. And one of the difficulties with healthcare in the U.S. is typically if one doctor has attached a diagnosis to you, a doctor from whom you're seeking a second opinion takes the diagnosis as given and just talks about different treatment options. And really what needs to happen is you need to go back to square one and ask if the diagnosis is correct.
Well, do you think that there's still like a code of like a thin blue line, where the police have, where there's the doctors, their position isn't that they're second guessing that, or don't want to re-diagnose or something.
Well, that's possible, but I think if you're looking at it from the patient's perspective, it's hard to say that the most important thing is to make sure that one doctor isn't offending another when the issue is it may cost you your life. So I think you have to ask those questions.
But it's crazy the way the other dynamics come into play sometimes. But
it is tricky.
So now I see in your book you also have a clearly delineated line of questioning for you know, different, different approaches.
For what kind of treatment to get. So when you're offered a treatment, a good question to start with is, what other options are there? And then for each of the treatments, you might ask, well, how is success defined for this treatment? For example, for some treatments, a doctor might consider it a success if it reduces symptoms by 25%. Well, if you don't know that that's how the doctor defines success, and you get a treatment thinking you're going to be 100% better, you'll be very disappointed. So finding out what success...
Realistic expectations,
how
or what's clinically proven to be,
yes,
the efficacy.
Right. Yeah. And then the next question is, what percentage of the people get that good result? Because for some treatments, only 30% of the people actually get the desired result. And the rest of the people, the treatment just doesn't work for. A further question to ask is, what do patients like most about this treatment? And a related question is, what do they like least about it? So now you're not asking, what's the doctor's opinion about the treatment? You're asking about the people who have to live with the results of it. What do they like and what do they not like?
And do you find that doctors normally have instantaneous answers for those things, or?
It's sometimes a little bit tricky to get that information because doctors really focus on their view of the treatment. It's a little harder to find out, but you can. Consumer Reports and some other services are starting to track that kind of information. What do patients say? So you might want to find out things like, is there a lot of pain with this treatment, or how long does it take to recuperate? And then it's useful to be clear about what your priorities are. For instance, a single mother with 2 small children might decide not to have surgery that would have her laid up for 3 months because it just doesn't fit her life. She can't take care of her family that way. Someone who has a little more latitude in their schedule might opt for surgery if it seems like that might get a better result than some other treatments. But the mother of 2 small children might be satisfied with a slightly less beneficial result if it doesn't disrupt her life completely to get it.
If it gets from, let's say, dysfunctional to functional,
yes,
yes, whatever that might be, whether it be pain or whether it be, digestion or that type of thing.
That's exactly right.
You mentioned in your book about patients keeping a copy of records of their medical history.
Yes.
And that saving a lot of time rather than being potentially a blank slate when they go in.
Yes, and let me talk about 2 things there. One is medical records in general, and the second is test results, medical test results. What the research shows is that 25% of medical records have errors in them that only the patient would know. So if there's information in your medical record that's wrong, your doctor may draw the wrong conclusions about what's wrong with you, or might give you a treatment that you previously had that you had a bad reaction to without knowing it and without meaning to. So one reason it's important to get your medical records is to make sure they're accurate. A second point about having your own medical records is that you're frequently the only one who knows all the doctors you've seen and all the treatments you've had and the different diagnoses you've been given, because doctors just have their own records. They don't have everybody's records. And if they don't know what else has happened with you, and you don't know because you don't have the records to help you tell them, they could be starting over from scratch. They could do completely the wrong thing, not because they have bad intentions, but because they just don't have the information. A third point is that studies show that people very often don't get their medical test results. And in fact, about 7% of the time, people don't get results that indicate that there's a major problem that needs immediate medical attention. And in those cases, people can be severely harmed and could even die. The test was done, the results have come in, but nobody tells the patient.
Well, sometimes I hear that from patients where they'll make a complaint about a doctor. Well, I had that test done, 2 months ago, and I haven't heard from anybody or
Then they
anything.
need to call.
Well,
Yes.
So
Yeah.
there is
Yeah.
patient responsibility is part
Yes.
of it, and then obviously the doctor's side. Well, now, in your research, has there been anything that comes up with the superfluous repetition of medical testing?
There's a lot of excess medical testing. Sometimes if people see 3 doctors, they have the same test 3 times, and they don't need to. And if they had their own medical records and they took them to the doctor, they could, first of all, eliminate the delay in having anything happen, because, well, you have to go here, have this test, and in 6 weeks come back
Right.
and we'll talk about the results. They could eliminate that delay. They could eliminate the expense. They could eliminate the risks. Most medical tests have some kind of risk associated with them. So they could streamline things, get faster help when they need it if they had those test results.
Nowadays, like with advanced, advanced imaging and stuff like that. I mean, like you take MRIs. It's a wonderful tool. As a chiropractor, sometimes people will come in. They'll just have they woke up with a stiff neck, and the patient. Well, no, I need an MRI of your neck. Well, no, you don't need an MRI of your neck. You're not going to have any pain in 2 days from now. I don't think that you need an MRI of your neck. I think some of those things may be not doctor-driven, but patient-driven also.
Yes. I call that the yellow pages phenomenon. People think if something's wrong, the immediate thing to do is look up the expert in the yellow pages and go get an expert's help with the highest tech approach that you can get. And that's not always the right thing.
Yeah, well, because most things see and treat easily.
Yeah. Yeah. Yeah.
Now, what about lifestyle in this component of what you're advocating in the book? What are your observations on lifestyle and all of this?
Well, one of the points that a number of researchers have made is that you could probably eliminate about 80% of heart disease and diabetes and so forth if people made different choices in terms of diet, exercise, alcohol, tobacco, and stress management, if people engaged in different behaviors. So there's a sense in which it's counterproductive to be giving so much power to the healthcare system to solve everything when there's more we could do.
Bad behavior may be contributory towards that.
Yeah, there's more that we could do. But there's still a lot of things that people can do when they do need to engage the healthcare system. For example, if people are in the hospital, there are 5 steps that they can take that will increase the odds that they'll get out in better shape than they came in. One of them is to ask if they're at risk for blood clots. Most people in the hospital are at risk for developing blood clots.
I've heard of 3 cases of that in the past month.
Yes.
As a consequence of
hospital care.
Yeah. Well,
surgical care.
It's just
Yes.
as a happenstance of what needed to be done.
Yes, and the federal government considers these blood clots to be so completely preventable that Medicare, the insurance program for the elderly, won't pay hospitals to treat them because the hospitals should have been able to prevent them in the first place. But they typically aren't prevented. So people need to ask, am I at risk?
What's causal for that? I mean, just a non-application of blood thinner after. I mean,
Well, there are a number of treatments. There are compression devices that will keep the circulation going. That helps prevent them. There's getting people up promptly after surgery to start walking around.
Okay.
There are drug treatments. So there are a number of ways to treat it,
but some as simple as just get up and get going.
Yes, absolutely.
I find even with spinal surgery now,
yes,
that many times they get the patient up and moving, or,
yes,
real quick. They want
yeah,
them. They want to know that they can move around and.
Yes, and the real root cause, I mean, the reason these things aren't done is that the attention in a hospital is on the actions that the doctor takes. It's not on what happens to the patient as a result. It's, again, we're back to the belief that everything works perfectly, and so people don't watch for these side effects and complications and don't work to prevent them when they're very easy to prevent. So a second point is infections. 99,000 people a year die of infections that they pick up in the hospital. So let me say that again. 99,000 people a year die of infections that they pick up in the hospital. And the main cause, according to government studies, is that care providers, doctors, and the people who work in hospitals don't wash their hands before touching patients. So fewer than a third of hospital workers routinely wash their hands before they touch patients. Doctors, fewer than half wash their hands.
I would have thought that would have solved that one, you know.
Well, 160 years ago, when it was first discovered that washing hands saved lives, that you would think that it would have been applied. But again, the actions aren't so much on what, the attention isn't so much on what happens to the patient. The attention is on what are the treatments being delivered. And so these sort of side effects and complications aren't given as much attention as they need to get. So a third thing that people can do in the hospital is make sure that they have a list of all the drugs that the doctor has ordered for them and the doses and how often they're supposed to get it. Because hundreds of thousands of people die every year of side effects of drugs, and another federal study, national study, concluded that the typical hospital patient is subjected to one drug error each day. One a day. It's a great slogan for a vitamin. It's a terrible slogan for drug errors in hospitals. So people need to know what their doctor has ordered for them. If every time somebody comes in, they need to check what's being brought, whether it's an IV or a pill, whatever, and make sure that it is what the doctor ordered. Now, a fourth point is to have someone who can advocate for you, because you may be out of it when you're in the hospital.
Right.
So around the clock, to have family members or friends who can sit there, can be with you, and be sure to ask questions if you can't, and to look out for you.
Yeah, I agree with you 100%. Even, you know, especially with the elderly and with pain medication, I find that you know, their family wants them to be comfortable, you know, and they don't want them to be in any pain. But the pain medication makes them totally loopy.
Well,
I mean, and out of it, and they don't metabolize. Their liver just doesn't metabolize those drugs, and it influences their recovery.
There are long-term consequences of that. In the intensive care unit, between a third and two-thirds of patients slip into something called ICU psychosis or delirium. And what it means is that they're literally they become insane in as little as 24 hours. It's a combination of the drugs they're given with being under bright lights 24 hours a day, 7 days a week, loud noises at frequent but unpredictable intervals. These conditions literally drive a significant percentage of the people in an ICU insane. And doctors typically have said, oh, don't worry, it happens to everybody in the ICU. Once they get home, they'll be fine. But relatively recent research says that's not true. That in the 6 months following an ICU stay, people who went over the edge into psychosis die at 3 times the rate of people who were equally sick with the same thing who didn't go over the edge. And if they survive, they may experience long-term cognitive problems. They may never go home again. They may end up in a nursing home, not because of the initial problem that put them in the ICU, but because they were driven insane by the conditions.
It's kind of like a medical Stockholm syndrome, you know, where it's, you know.
It's the consequences are very, very severe. And again, people just don't pay that much attention to it, because the attention is, what does the doctor or nurse need to do to provide treatment? It's not what's going on in the head of the patient.
Right. I know something simple like that that the power of light,
Yes.
and is
If you dim the lights at night,
I mean,
you can go a long way.
yeah,
to help
absolutely,
it. Yes.
absolutely. I know even if it, I like it pitch black to
Yeah.
sleep right, and
Yeah.
but I know that they've done studies on
Yes.
that whole aspect of light, and it would probably even save money, really.
Yes,
I
right.
mean, on
Right.
top of it, at a time
Right.
in which we're trying to cut the electric bill down.
Yeah. Yeah.
You would think that with all of these sensors that they have nowadays, it wouldn't be that difficult
Right.
to bring something like that online
A
for
lot of
people.
these things are about awareness and just the will to do it. It's not technically difficult. It's not expensive to do it. It's just a matter of really focusing on what happens to the patient as a result of the care they're getting. And that brings us to the fifth point. The fifth thing people can do in the hospital is speak up if they think something is going wrong. The federal agency, it's a national agency that accredits hospitals, has published 14 different brochures saying what to watch out for when you're in the hospital. And they have titles like Help Avoid Mistakes in Your Surgery. So this is the organization that spends its life crawling around behind the scenes in hospitals. And they're telling people, watch out and speak up. So if anybody would know what goes on in hospitals, they would, and that's their advice.
A little bit of a squeaky wheel getting what it needs, not necessarily the grease, but just what it needs to function. That's just very, very interesting. Now the point with what I was trying to make was now there's the whole problem with MRSA,
Infections.
in infections,
Different kinds of infections.
different kinds
yes.
of infections
Yeah.
that are antibiotic-resistant infections that even have a greater need for you to try to get out of the hospital sooner.
Yes.
And
Yeah.
I mean, so the greater the recovery, the better.
The faster
the
you
better
recover,
that
the
is.
better you're out of the hospital, the better it's likely to be for you long term. Yes, and when I say that you should ask everybody to wash their hands when they approach you, it means everybody. It means your spouse, your kids, the clergy, an administrative clerk who comes in to get your menu or something like that. Anybody who's going to touch you, you want to ask them to wash their hands or use a sanitizing gel, something. Because let's say that your spouse comes into the hospital. Well, they're touching elevator buttons, maybe the coffee machine, the counter, the doorknob. They're able to pick up infections floating around the hospital and pass them on to you.
So one big soup out
yes.
there. But concentrated in the medical, regretfully in a place where people are sick.
Yeah. That's right.
That's right. Now, what separate from what we've talked about, is there another area of core focus that we need to get out to our viewers about the nature of what's in your book? And that's a really core focus that we haven't touched on so far.
One of the things that I would say is important is that it's useful to look at healthcare, again, from the perspective of the patient and ask what they need. So here's an example. In Killer Cure, I talk about 14 steps in the process of healthcare. One of them is dealing with the meaning of a diagnosis, so the impact and significance of a diagnosis. So if someone is told that they have multiple sclerosis, how do they deal with that? That can feel like running into a ton of bricks. And then it can be difficult for people to know how to proceed. So for example, in the book I talk about a woman named Shannon who was diagnosed with multiple sclerosis. And for several months, she was really afraid that some symptoms she had meant that she couldn't drive a car, that she shouldn't be driving a car. But she didn't want to ask her doctor because she has 3 young children. She just couldn't see how she could manage her life without being able to drive a car. So for 3 months, she was carrying this big weight around of, oh no, maybe I can't drive. finally she talked to her doctor about it, and she immediately found out two things. One, her symptoms had no impact on her ability to drive. There was not a reason that she had to worry about that. And the second was that her symptoms could be readily addressed with physical therapy. But the fact that she wasn't really getting any help in sort of absorbing the meaning and impact of this diagnosis on her life.
The gravity of it.
And how to deal with it and what questions to ask. So she was living under great stress for about 3 months, which doesn't help if you have multiple sclerosis.
Oh, no. That can certainly contribute to a bout, that's for sure.
So one of the things that the healthcare system could do better is to anticipate the mental and emotional needs of people who are given serious diagnoses and help them sort through the meaning and impact of a disease. So there are a couple of dozen things like that healthcare could do differently. Another topic that I talk about in the book is sort of summarizes how patients are really viewed in the healthcare system. And I'll give you an example. Right now there's a debate in the medical community about whether young doctors in training should have their hours limited, because half of all medical mistakes are created by people in their first year of training in a hospital after they've completed the academic work, after they've been on duty for more than 24 hours.
I know that they work those interns to the bone. It doesn't make any,
So if you think half of all these, we've been talking about 600,000 people die as a result of problems in hospitals. So if you said 300,000, or take a different number, it doesn't matter, 100,000 that people die as a result of the hours that these young doctors in training are operating under, putting in. And yet there's a debate, a polite multi-year debate about whether it's good to reduce those hours or not. Now, if you think about an analogy, supposing the airline industry said, okay, well, in order to train good pilots, we need to have them flying for more than 24 hours without any rest breaks, so they get used to handling different situations. And, it's true that about 100,000 patients a year die, passengers a year die. I guess the pilot has a parachute or something. He doesn't die.
Right.
But the passengers die. But, it's necessary to do that.
No, I agree with
to
you
train
100%.
good pilots.
Boy, this was a terrific amount of information that we've got here today. And it's been wonderful having and interviewing you on the show. And I want everyone out there to buy her book, Killer Cure. And thank you, Elizabeth, for being a part of the show and coming aboard.
Delighted to be here.
Okay, thank you. For Natural Healthcare Alternative, I'm Dr. James R. Golding, and thanks for viewing.